All right, everybody, thank you for joining us for today's webinar. We're so glad that you are able to take time out of your day and join us for this Zomedica-sponsored webinar. Our topic today is going to be canine hypothyroidism. It's being presented by Dr. Deborah S. Greco. After receiving her DVM from the University of California, Davis, and a PhD in veterinary pharmacology from Texas A&M University, Dr. Greco joined the faculty of Colorado State University, where she taught veterinary internal medicine for 12 years. And in 2002, she was promoted to full professor. Dr. Greco then moved to New York City and practiced at the Animal Medical Center for several years before joining Nestle Purina in the Global Nutrition and Scientific Communications team, from which she retired in 2021. She provides a scientific support to global markets and has expertise in the communication of veterinary internal medicine and nutritional information to technical audiences such as veterinarians, breeders, and veterinary technicians. She has been the editor-in-chief of a veterinary journal for more than 15 years and has authored over 200 scientific articles and book chapters. Dr. Greco is considered an authority in the area of small animal endocrinology and feline medicine. In fact, she was awarded the 1996 Pfizer Award for Research Excellence and the 1998 American Association of Feline Practitioners Research Award for her work in dietary treatment of feline diabetes mellitus. Dr. Greco has served as president of the Society for Comparative Endocrinology, as program chairman for ACVIM in 1995 to 1997, and as board member of the Western Veterinary Conference from 2013 to 2016, as well as editor-in-chief of Topics in Companion Animal Medicine from 2000 to 2018. So without further ado, please join me as we welcome Dr. Deb Greco.
Thank you very much, Susan. It's my pleasure to be here today to talk about canine hypothyroidism and some of the new developments in point of care diagnosis of endocrine diseases. So I'm going to start by talking about primary hypothyroidism. In fact, most dogs develop primary hypothyroidism, probably about 95 to 98% of them. And that particular condition is caused by what we call lymphocytic thyroiditis, where there's a lymphocytic plasmacytic infiltrate in the thyroid gland that results in kind of a sequential destruction of the gland over months to years. It's similar to the condition in humans known as Hashimotos thyroiditis, and it does have a genetic basis in both humans and the dog. If you look in the literature, you'll see that many textbooks will say that hypothyroidism is caused by idiopathic thyroid atrophy. But I might caution you on this because this was put in books because they were looking at histopathology of dogs that died and then had hypothyroidism during their lifetime. So the end stage of lymphocytic thyroiditis is actually thyroid atrophy because the gland becomes completely destroyed. So, you know, as we know, the term idiopathic is, you know, starts with idiot. So means you don't really know what's causing it. But 95% of hypothyroidism in this dog is due to lymphocytic thyroiditis, actually. Maybe less than 1% is due to a thyroid tumor or neoplasia. They're pretty rare in dogs. And then the other 2 to 3% would be congenital hypothyroidism, which is actually more common in the cat than the dog. And excuse me, that can be caused by a lack of development of the thyroid gland or by having a genetic disease that results in lack of certain hormones like thyroid peroxidase, or enzymes rather, thyroid peroxidase, which is important for secretion of thyroid tissue. So, what is the basis of the genetic predisposition? Well, Lorna Kennedy did some papers in 2006 and 2010, and also there's another one in 2015 looking at the dog leukocyte antigen haplotype. And was found that this particular allele is also associated with immune-mediated diabetes in the dog. So common breeds that they've identified this genetic mutation include golden retrievers, beagles, Rottweilers, Irish setters, dachshunds. And if you're interested in the breed shared risk haplotype, this paper by Bianchi in PLOS One gives the information as to looking up this particular paper to determine what breeds have had genetic basis proven. So immune-mediated thyroiditis starts with this genetic predisposition to hypothyroidism, and we see cell-mediated immunity attacks directed at the thyroid gland itself. That results in the leakage of a very large protein called thyroglobulin, and thyroglobulin normally never gets into the bloodstream in a normal individual because it's contained within the colloid in the thyroid gland itself. So when we get damage caused by cell-mediated immunity, that causes leakage of thyroglobulin. Because it's such a large protein, the body really is going to develop antibodies against it because it sees it, number one, as a foreign protein, something like a virus that has invaded the body. Number two, it's going to produce antibodies to thyroglobulin. So once the antibodies are formed, then we start to get recruitment of lymphocytes and plasma cells within the thyroid gland itself and lymphocytic destruction of the thyroid. And this is a slide showing Hashimoto's thyroiditis. And you can see on the right side is the more normal thyroid gland. And you see the colloid, which is this sort of pink stuff surrounded by white. Those are the follicles and within the thyroid gland. And then on the left is an example of Hashimoto's thyroiditis. And you see that those eosinophilic or the red areas have been filled in with lymphocytes and plasma cells, and that there's a lot of fibrous tissue also in this particular slide showing the lymphocytic infiltrates. The breeds we see most commonly affected by hypothyroidism, probably far and away the most common is golden retriever, although I just spoke at a conference with a dermatologist. He sees a little bit different. Almost all of his are golden retrievers, and I tend to see more of the smaller dogs. So in my practice in Palm Springs, we're seeing a little bit different types of patients. But dachshunds, I see a lot of dachshunds with hypothyroidism. Dobies, don't see too many of those. Schnauzers, Great Danes, the miniature and toy poodles, boxers, Irish setters, and English pointers. This is a study that was done out of Michigan State, and they were able to look at thyroglobulin antibodies in 140,000 serum samples submitted for investigation of thyroid disease. And Michigan State does a lot of work with breeders. So a lot of these dogs probably are coming from large breeding operations, either hunting kennels or places like that. So some of the breeds that we're seeing here are ones that we don't see commonly in practice. For example, the English setter, I don't think maybe I've seen one in private practice. But at any rate, so this is probably a kennel that's screening their patients or screening their dogs. And you see, there's only about 600 setters here, but the prevalence is a third of them are hypothyroid. Similar situation with the Old English Sheepdog, not a common breed, but a high incidence, probably looking at a single cohort that is related. Boxers, we have a few more samples there, have about a 20% prevalence. Same here with Pit Bull Terriers. And then if we go down and look at the Golden Retriever, it's further down the list, but we have almost 17,000 samples from Golden Retrievers. So still very high incidence in those dogs. And those are not likely all related dogs. I mean, they're from the same breed, but they're not closely related. So the age of onset of hypothyroidism, I think most people believe that hypothyroidism develops in middle age. And in fact, that's not true because we're looking at the onset of hypothyroidism. By the time they're middle aged, they may be fully hypothyroid, but they start becoming hypothyroid if they have a genetic predisposition. They can start as young as 6 months of age. And on average, it's about 2 years of age where they start having lymphocytic thyroiditis histopathologically. So remember, this is an autoimmune disease. The age of onset is really young to middle age. The older literature states middle age to older, but most of those dogs that they were diagnosing in the past were waiting until the dog was severely hypothyroid before they were able to diagnose them. So earlier diagnosis has been helpful for us to identify dogs with this condition earlier. And if we look at the two studies that looked at familial hypothyroidism in the dog, one in Borzois and one in Beagles, they found in the Borzois that all of the dogs in that particular family were affected by 2.5 years of age based on thyroid biopsies. We don't do many of those in practice because they can be quite bloody. Manning et al., this paper was looking at a family of beagles. It was a much larger study, and they found that the dogs actually were showing signs of hypothyroidism as early as 1.5 years of age and as late as 5 years of age. This is another graph from the same data set from Michigan State that I showed you earlier. And you can see that there's an age distribution profile. So let's look at the pink line first. And you see that's called subclinical. The SC stands for subclinical thyroiditis, which means that these animals had antibodies to thyroglobulin and perhaps some clinical signs associated with it. And you see that the subclinical, well, actually they don't have a lot of clinical signs, but they have markers like thyroglobulin and autoantibodies. And as you can see, we can see some of these patients as early as 6 months of age, and then you see it kind of peaks at 1.5 to 2 years of age. Then those antibodies taper off as the dogs become older. Actual lymphocytic thyroiditis of the thyroid gland based on biopsies or evidence of elevated TSH, low free or total T4, and thyroglobulin antibodies. You see that the incidence starts to peak at 2 to 3 years of age, and then it peaks out at 3.5 to 4 years of age, and then it tapers off. And then finally, when you get to thyroid atrophy, that doesn't start, you don't start to see a complete destruction of the gland until about sometimes as early as 4 years of age, and then maybe peaking at about 7 or 8, 7.5, and then of course tapers off after that. So you can see the first sign is the subclinical thyroiditis, then the lymphocytic thyroiditis with symptoms, and then finally when their thyroid is no longer producing any T4, they become what we call idiopathic. So thyroid hormone is also affected by age, so in normal individuals. And in fact, young animals, so in the first 3 months of life, they have T4 and free T4 levels that are 2 to 5 times the adult normals. So if you were to have a puppy come in that you suspected was a dwarfed hypothyroid puppy, and you were to measure total or free T4 and found that it was in the normal range for an adult, that's too low for a puppy. We also see age-related decreases in total T4, serum T4, from about 2 years of age, where it's on average 2.1 micrograms per deciliter, that by the time they're 10 years of age, it's dropped to an average of about 1.4 micrograms per deciliter. Also, if you were to give TSH, exogenous TSH, and measure how much response they have to TSH. The young dogs will regularly be able to secrete about 4 micrograms per deciliter over baseline, whereas old dogs will only be able to secrete about 2 micrograms per deciliter. Also, there's an effect of breed and obesity on serum T4 and T3. We know that a lot of the sighthounds, like greyhounds, Scottish deerhounds, whippets, for example, some of the like the giant schnauzer, these animals will have about half the total T4 and T3 of other breeds, like a golden retriever, for example, or a Labrador. And that has prompted Michigan State to try to work on some breed-specific normals. And I don't know where they are in that project, but I know that they were funded by the American Kennel Club because breeders are very concerned about this condition in dogs. And then we also know that, excuse me, obesity can cause mild increases in total T3 and T4. So the cardinal signs of hypothyroidism include a tendency to generalized obesity, mental and physical lethargy, classic dermatologic signs, including alopecia and thinning of the hair coat on the trunk of the body, usually symmetrical, and also infertility. But I'm going to just talk about infertility for a moment here. Even though it's associated with hypothyroidism, we now know that infertility is not caused by hypothyroidism. So when the thyroid gland, when I mentioned that they have a genetic susceptibility to injury to the thyroid gland, they also have the same antigen is present in the testes and also in the ovaries. So these animals also develop autoimmune destruction of their ovaries and their testes when they have hypothyroidism. Not all of them do, but some of them do. And so if somebody presents an animal to you for workup because they, for example, it's a male dog that has a low sperm count, and you find out that they are indeed hypothyroid, if you give them supplement, it doesn't help their infertility because there's a lymphocytic plasmacytic orchitis going on. So those dogs definitely should be removed from the breeding pool because they will perpetrate this infertility issue. So really, some of the things you want to look for in dogs with hypothyroidism, the very first sign is going to be mental and physical lethargy. And in most pet dogs, that can be kind of difficult to determine because we don't really demand that much of our pets, right? And they come to the door when you come home and things like that, and they pay attention to you. But where I tend to see this more often is in performance dogs. So if I have a client who has maybe an agility dog or maybe a hunting dog, and they're telling me, well, you know, the dog just doesn't want to go out and run the course or doesn't want to go out and hunt or he wants to come in early, those are all subtle signs that they may be developing hypothyroidism. Also, this tendency to generalized obesity that, again, in a young dog, maybe it's been spayed at 6 months or a year of age, and the owners say, well, they got fat because you spayed them. Well, that is partially true, but it could also be that tendency towards obesity. That's an animal I might screen for hypothyroidism. The skin and hair coat changes are going to take a little longer to develop rather than some of these tendencies toward obesity or the lethargy. So mental dullness, weight gain, alopecia, seborrhea, sika and oleosa, a coarse, dull hair coat, excessive shedding, because what happens is they have a prolonged telogen phase. So there's no new hair growing in to replace the old hair. So it's not like hypothyroidism causes the hair to fall out. It just doesn't, it causes the new hair not to be able to grow in and push the old hair out. So that's why you see this dull hair coat. Also, they can have exercise intolerance and muscle weakness. It's not generally marked, but again, in our performance dogs, it may show up. Tragic facial expressions and myxedema. I'll show you a picture of that. Hyperpigmentation of the skin, cold intolerance. So I'll ask owners, does your dog like to sit in warm places, like sit in the sun, or maybe next to the refrigerator, where it's warm on the bottom, where the excess heat is being put out from the bottom of the refrigerator. Reproductive abnormality, that's where breeders will often bring the dog in, but don't give them false hope about it. And then very uncommonly, they may have bradycardia. So here's a couple of examples of very classically hypothyroid dogs that are in the end stage of hypothyroidism. Mr. Big there, he's probably about 20 pounds overweight. He is a standard dachshund. He's not a mini, but still, he's a big boy. And you can see he's got that kind of tragic facial expression, very similar to the boxer here. And you see that the boxer's face looks kind of puffy. His hocks and everything look kind of stocked up, like there's fluid there, but it's a non-pitting edema. So if you press your hand, you don't leave a dent in that edematous looking area. Some of the other signs, so metabolic myopathy has been reported in dogs with hypothyroidism, about 30% of them, but megaesophagus has never been proven to be associated with it. Neuropathies such as the facial and vestibular nerves, they can be affected in hypothyroidism, can be unilateral or bilateral. And in humans, the most common neuropathy is carpal tunnel syndrome. So we think that what's happening is that in dogs, the facial and vestibular nerves exit the skull near the ear. And when they develop myxedema, it compresses the nerves. And so when you supplement them and get rid of the myxedema, which goes away within a week or so, a lot of times these dogs their head tilt and their facial nerve paralysis will resolve very quickly after supplementation. However, one neurologic disease that we don't see associated with hypothyroidism is laryngeal paralysis. This has been reported in the literature, but it's not associated with hypothyroidism. It's actually a genetic disorder, usually seen in Labrador retrievers. And then uncommon clinical signs of hypothyroidism. Now, as an internal medicine specialist, I'm more likely to see one of these conditions than I am to see the dermatologic conditions, which I'll talk about after this. So one of the things that I want to point out is that you can see a thyroid hepatopathy because hypothyroidism causes changes in lipid metabolism. So we'll see elevations of ALP as a result of hypertriglyceridemia. Also vestibular disease. Oh, and I might also add that I don't have that on here, but as kind of related to the thyroid hepatopathy, we sometimes see mucoceles of the gallbladder. And again, it's because of the lipid abnormalities with hypothyroidism. Vestibular disease or cerebrovascular accidents as a result of fat emboli from the hypertriglyceridemia. Myopathy, I mentioned. Megaesophagus, very, very rare to see that. Insulin-resistant diabetes mellitus, that's how I usually diagnose hypothyroidism. I have a difficult to regulate diabetic. And remember, if you have insulin resistance in a diabetic dog, the first disease you should look for is hypothyroidism because they have a shared genetic basis, not Cushing's disease. Cushing's disease is a rare cause of insulin resistance in the dog. Gastrointestinal signs such as diarrhea and constipation. Occasionally we see that. Galactorrhea, which is a milk production in a spayed female or a male dog. Sometimes, occasionally, we see the dwarfs or the cretins associated with it, and very rarely myxedema, stupor, or coma. Dermatological signs of hypothyroidism are the most common reason why dogs are presented to the clinic. Symmetrical or asymmetrical alopecia, usually non-pruritic, but if they have a severe pyoderma, they can be pruritic. Dull, dry hair coat, the seborrhea and ceca and oleosa are due to the lipid derangement from hypothyroidism. Rat tail, puppy hair coat, easily epilated hair, recurrent pyodermas with a risk for methicillin-resistant staph. So we got to keep that in mind. So the skin immunity is impaired in dogs with hypothyroidism. They often have a history of recurrent otitis and malassezia. So in between interdigital malassezia or otic malassezia. A tragic facial expression, thickened, cool skin with mucin deposition. So completely opposite of what you'd see in Cushing's, where you see real thin skin. In hypothyroid dogs, you see very thick skin. Hyperpigmentation and poor regrowth of hair after clipping. So this is kind of the derm part of my lecture, and we can see, especially early on, asymmetrical alopecia, particularly in the large breed dogs. And oftentimes they'll have a poor coat, sometimes it's kind of bleached out, and secondary infections are also common. Here we see the rat tail that I had described before. So they, for some reason, tend to lose the hair off the tail first. And so apparently the symmetrical alopecia doesn't occur in the first few months of hypothyroidism. As I said before, there's a prolongation of hairs in telogen phase and impaired anagen promotion. So the hypothyroid dogs tend to have hair loss in areas of trauma or pressure. And then a large breed dog, that's going to be their side where they lay down, their elbows, sometimes where their collar is, the top of their nose, and the base of the tail. The fatty acid abnormalities may lead to a high incidence of ceruminous otitis with secondary bacterial or yeast otitis externa, as you can see in both these pictures here. And a lot of times, Cocker Spaniels are another breed that we tend to see this in, hypothyroidism in, genetically, and they often also have fatty acid abnormalities as a result of being cockers. Mucopolysaccharides and hyaluronic acid lead to this accumulation and thickened, puffy skin. It's usually over the head and face. That leads to this sort of tragic facial expression. That, together with the facial nerve paralysis, gives us a tragic face of a hypothyroid dog. This is a Shar-Pei. They have naturally occurring mucinosis, but when they have hypothyroidism, it's really, really severe. And you can see they almost look like blisters within the skin. And what you can do is actually open up one of those blisters with a small needle, and you get out this, what almost looks like joint fluid, because it has all these mucopolysaccharides in it. The blonde frizzies, so we used to see a lot of Irish setters. I don't really see them that much in the practice anymore, but they tend to get what we call the blonde frizzies, where their hair starts to lose pigment. And you can see this in golden retrievers too. Other clinical signs, cutaneous-wise, include susceptibility to infections, Staphylococcus and Malassezia. So with a recurrent pyoderma dog, you always want to check thyroid status because it can be as many as 15% of the cases. Adult onset Demodex is pretty rare, but occasionally you will also see that with hypothyroidism. With regard to clinical pathology, some of the things that might prompt me to test a dog for hypothyroidism, including hypercholesterolemia, so blood cholesterol or serum cholesterol that's over 500 milligrams per deciliter, or hypertriglyceridemia, anything over 200 milligrams per deciliter, Anemias, which are normocytic and normochromic, maybe about 10% of the cases have that. Low sodium, which is mild, but maybe about 30% of the cases show low sodium. Increased ALP due to thyroid hepatopathy and the lipid abnormalities, generally in the range of 1,000 to 1,500. And that occurs in maybe 10% of the cases. Same with the elevated creatine kinase as a result of the myopathy. So let's start with a case. This is Graf, the house hippo. He's a 5-year-old male neutered Rottweiler. He's gained a lot of weight and he's lethargic. He weighs 182 pounds with a body condition score of 7 out of 9. He eats 1 cup of RD, which is a restricted calorie diet, lots of horse poop on the ranch. And even though he exercises every day on the ranch, he's been less willing to go out and do that in the last few months. He also likes to lay by the refrigerator in that warm place right at the bottom. His minimum database shows that he's mildly anemic, has a very low total T4, a high cholesterol, high triglycerides, and low sodium and high CK. So he has everything except the high ALP, basically. So when we see a patient like this, we could probably just make the diagnosis based on the blood work, the low total T4. If it walks like a duck and quacks like a duck, you can diagnose it. But I just want to show you what his thyroid panel looked like. Not only was he really low in T4, but he was low in T3, in free T4, and his endogenous TSH, as we would expect, is high as a result of a loss of negative feedback to the pituitary gland. His thyroid autoantibodies are negative because he's 5 years of age, and if he had them, he would have had them as a younger dog. This is a 9-year-old Brittany, female spayed, with a history of ocular discharge on the right side. She was treated with topical steroid antibiotic with no improvement. Physical exam is pretty unremarkable, but on neurologic exam, it's clear that she has a facial nerve paralysis, which is bilateral. And her trigeminal nerve is normal. We did some blood work on her, and she had a mild anemia, low sodium and high cholesterol, but the triglycerides were okay on this dog. Thyroid testing showed that she was pretty severely hypothyroid with a high TSH. And then while she was in the clinic with getting her blood drawn, she developed a right-sided vestibular ataxia with no signs of central disease. So we attributed it to the hypothyroidism, and she, in fact, improved after 2 to 3 days of thyroid supplementation. I like to say that the disease hypothyroidism is pretty easy to diagnose, and this is a kind of a joke because this is an algorithm of how in the 1990s we used to diagnose hypothyroidism. We would use a TSH stimulation test because we did not have free T4 by dialysis, or we didn't have it in all the cases, and we tended to use TSH stimulation tests for diagnosis. It turns out that every test for hypothyroidism has 1 or 2 drawbacks. So total T4 is not 100%, neither is free T4 or endogenous TSH. It turns out that the only test that can differentiate almost 100% of the time between a hypothyroid dog and one with non-thyroidal illness is something called a quantitative protectate scanning of the thyroid gland. And we don't have access to that. So let's talk about the tests we do have. We'll start with serum total T4, and I'll show you several of these graphs. They're called box and whisker graphs. we have 150 normal dogs, 54 hypothyroid dogs, and 54 dogs that they suspected hypothyroidism, but turned out to have normal thyroid function. So you can see that most normal dogs have a T4 somewhere in the middle range. There's a few outliers where some have some high T4 levels. We don't really know what causes that. Of the hypothyroid dogs, most of them have a T4 that is below the normal limit of normal. So that green area there is the normal range. And you can see some of them are in the low normal range, but most of them are down below that. There's a few that are really high, like 460 or 210. Those are dogs that actually have autoantibodies to T4. That's why it's high. And then you see that our euthyroid sick dogs, excuse me, that moved. The euthyroid sick dogs, most of them are in the normal range, but there's a little bit of overlap between the hypothyroid and the suspected or euthyroid sick dogs. So that's where total T4 as your only test kind of falls down a little bit, and then it's only about 80 to 85% accurate. If we look at serum-free T4, and this is, in this graph, this is serum-free T4 by equilibrium dialysis, and you can see that most of our normal patients have a normal free T4, but some of them have slightly elevated. In our hypothyroid dogs, most of them have low total T4, or excuse me, free T4. And most of our euthyroid sick dogs are more similar to the normal dogs. But there are a few that fall in that low free T4 range that are not hypothyroid. So not 100%, goes up to about 90% with that. So let's talk about the difference between free T4 and free T4 by equilibrium dialysis. Both of them measure the unprotein-bound form of T4, which is a small fraction. It's like less than 1 or 2% of the total T4 that's in the blood. So you have to have a very specific assay. The free T4 that is used in the TRUFORMA platform and also in IDEX, those are veterinary specific, whereas the T4ED was a test that was adapted for veterinary use, but it was primarily a human test. The free T4 is a chemiluminescent immunoassay in the case of IDEX, and in the case of TRUFORMA, it's a different type of technology that we'll talk about in a minute, but it's not chemiluminescent. If we look at the free T4ED, it's a radioimmunoassay, which is older technology that's pretty much been phased out in human medicine because it's hard to get rid of the radioactive components used for the test. Like, we have no place to store radioactive waste at this point. Whereas the IDEX assay measures light emission, and the TRUFORMA assay measures a shift in, it's more of a sonographic type of assay. So the free T4 is automated, so is the TRUFORMA, but the free T4ED is not automated, and that leads to poor reproducibility and precision compared with the TRUFORMA or IDEX free T4s. The incubation time is very short, and shorter for the TRUFORMA than it is for IDEX, and whereas for free T4ED requires an overnight assay, 2 to 4 working days for turnaround, and on the IDEX, usually the same day, but in my experience, I usually get back 2 days later. So the TRUFORMA is really point of care, so you're going to get it within 20 to 30 minutes of seeing the patient. The specificity in healthy dogs between these two is very similar. It's actually higher for the non-equilibrium dialysis methods. And the accuracy is very similar for both free T4 ED and regular free T4 from IDEXX or TRUFORMA. So here's the immunology technology in the TRUFORMA free T4 immunoassay. And so what you're going to do is look at the probe signal, and you look for a frequency shift once you have binding to the free T4, and then the frequency switches back afterwards. So it's that frequency shift that's being measured. So one of the advantages of the TRUFORMA is it's probably not going to be affected much by hemolysis or lipemia. Although, well, I would check with the technical people to make sure that that's true. But it seems that with this type of technology, it's different than the chemiluminescent assays, which require light to go through the sample. And this is just showing the correlation of the Immulite veterinary free T4 assay, which is basically what IDEXX uses, compared with the TRUFORMA free T4 assay. And you're seeing that as a very good correlation, 0.93. So that tells you that those techniques are very, very closely accurate. So they're going to give you the same result. Okay, so this is a scatter plot of free T4 ED and TSH, endogenous TSH concentrations, using the same data set that I showed you before. It's a paper by Mark Peterson from the 1990s. And the hypothyroid dogs are shown in the open squares, and the euthyroid sick the euthyroid sick or the euthyroid dogs, because they had some that were normal dogs, obviously. They're looking at those as the yellow circle here. And then if we look at free T4 on the horizontal axis and TSH on the vertical axis, you see that they have a cutoff for TSH at 1 nanogram per mil. Well, we know that that cutoff now is 0.4. So that's why I've got that yellow line there. That's at about 0.4 nanograms per mil. Because some of these dogs were misclassified based on what the TSH level was. So let's look at the hypothyroid dogs first. And you can see that most of our hypothyroid dogs, most of our squares are in this upper left-hand quadrant, which means their TSH is high and their free T4 is low. That makes perfect sense, right? Because low free T4 means there's no negative feedback to the pituitary, and the TSH will increase in an effort to bring the T4 and free T4 up. Now, you notice that they have misclassified. If that yellow line goes all the way over to the edge here on the left, you see they correctly identified these hypothyroid dogs, but there's like about 10 of them in there. But then now we have a bunch of these with a low free T4 ED, which is still in the normal range, but their TSH is high. So I think these are early hypothyroid dogs. And the way they decided if they were truly hypothyroid or not was by doing a TSH stim test, which is not an ideal test. So I think they were basically misclassifying a lot of these as euthyroid when they were actually early hypothyroid dogs based on the TSH. And you see a lot of them have that. They're got a free T4 by dialysis that's in the range of less than 20, right? It's on the low end here. So it's not supposed to be, free T4 is not supposed to be affected by euthyroid 6. So why are they down there in that range? Seems suspicious anyway. Okay, so let's look at this little patient, Max. He's a 12-year-old male castrated Yorkie. He was diagnosed with hypergenocorticism and referred for Pickwickian syndrome and a cough. His ALP was over 2,000. He had high triglycerides and cholesterol. He was treated for 3 weeks with trilostane and became Addisonian, so we had to stop that. On abdominal ultrasound, he actually had small adrenal glands and a large liver mass. So that probably explains the high ALP. His thyroid testing showed that his total T4 was right at the low end of normal, and his endogenous TSH was elevated, was over 0.4. On echocardiogram, he also had right ventricular hypertrophy and probable pulmonary fibrosis. So he's been managed now for 2 to 3 years with sildenafil for his pulmonary fibrosis and thyroid medication. This is a study looking at combinations of different tests. And I'll just point out that the sensitivity here, we have one study for low free T4 by dialysis where we're getting a sensitivity of 98%. But then there's a slash because another study showed that the low free T4 ED only gave you a sensitivity of 80%. So I'm not sure why there's such a big difference there, because that's a huge difference. If we look at the sensitivity of TSH, high TSH, we have one where one is 0.76 and the other one is 0.87. Again, that's kind of weird. And then also the specificity of 0.93 in one study and 0.82 in another. So my preference actually is to do a free T4 and a TSH, and that combination, I don't know why they're using only one thing for accuracy, but if you take the higher numbers for both of these, you're going to get a number that's much higher than that. It's going to be like 0.95. And notice that they ignored the 0.8 here in order to get an accuracy of 0.95, because that's impossible using that 0.8 for sensitivity. So I'm not sure that these numbers are completely correct, but my preference would be to either use a low total T4 and a high TSH, but if you have the free T4 available, I would use that with the high TSH to diagnose hypothyroidism. And so let's look at Zoe. She's a 7-year-old female spayed Corgi Sheltie Cross. Her chief complaint is weight gain, interdigital pyoderma, and otitis externa. And her laboratory values showed that she's had a sudden increase in ALP of 1400, and her triglycerides are over 600 milligrams per deciliter. We did thyroid testing. Her total T4 is actually in the middle of the normal range. Her free T4 is at the low end of the normal range, and her TSH is above 0.4. So given the clinical signs, the laboratory findings, and the high TSH, and the low normal free T4, I'm gonna say she's an early hypothyroid dog, and we went ahead and supplemented her. The next one is a 12-year-old mixed breed female spayed dog. On physical exam, TPR is normal. She's just there for dental disease. The owner wants blood work for a dental, and her blood work's pretty normal. She has some high triglycerides, but she just ate when she came in for this blood work. And you see that her total T4 is low. Do you follow that up? Probably not. I would look at this and say it's a 12-year-old dog. That's basically age-related change. And in fact, if you went ahead and tested her, you'd see, even though the total T4 is low, the free T4 is normal, the TSH is normal. There's no sign of thyroid disease here. Another young dog, Clementine, 2-year-old female spayed golden retriever. She came in for vaccination. They didn't have any complaints about her, but the client said, yeah, you know, her appetite's kind of not super good, and she's gained weight since she was spayed at 6 months of age. She has a dry hair coat and loss of her golden color. She's also had several bouts of otitis externa. I don't know if you can see here in this picture, she's worn off the hair on the top of her nose. She also has alopecia around her neck where the collar is, and also at her tail head. She does seem lethargic when we go into the room. Then we rolled her over and looked at her abdomen, and we could see some epidermal collarettes were suggestive of pyoderma. We did blood work on her, and that was relatively normal, including a total T4 in the normal range. Cholesterol is fine, triglycerides are fine, everything else is normal. So because we still suspected hypothyroidism, we went ahead and did a full panel. She had low normal total T4. She had very high total T3, and I'll show you why in a minute. Her free T4 was low, and her TSH was very high, 1.4 nanograms per mil. And her anti-thyroid globulin antibodies were high. So she's in the lymphocytic thyroiditis stage of her disease. This is showing you serum total T3 in normal hypothyroid and euthyroid sick patients. And you see the reason we don't use T3 to diagnose hypothyroidism is that, it doesn't really differentiate between these three groups. But autoantibodies to T3 are more common than autoantibodies to T4. So you see in hypothyroid dogs sometimes some very, very high total T3 values. This is Bridgette. She's a 7-year-old female spayed bull terrier. Her chief complaint is galactorrhea, a sudden onset of mammary enlargement, and the owner has noticed that there's milk dripping from her nipples. And she was spayed when she was like 6 months of age. So on physical exam, she's got a body condition score of 8 out of 9. She's really overweight. She has diffuse alopecia, particularly on the trunk, and her mammary glands are enlarged. Her thyroid panel, she was exquisitely hypothyroid. She had undetectable total T4, T3, and free T4. Her TSH was the highest we've measured so far, 11 nanograms per mil, and her thyroid globulin autoantibodies were negative. So what happens sometimes in these dogs that are very, very severely hypothyroid is that their pituitary starts to, it's cranking out so much TSH that the cells right next to the thyrotrophs, which are what produce TSH, are lactotrophs. And when they get stimulated, they start to hypertrophy when the thyrotrophs hypertrophy because they have a common progenitor cell. And so when the animal's really hypothyroid, those lactotrophs start to secrete whatever they can, and what they secrete is actually prolactin. And that's what causes the milk production. And it can be seen in male dogs as well as female dogs. So treating a dog for hypothyroidism, the dose is 22 to 44 micrograms per kilogram, either once or twice a day, or a handy rule of thumb is 0.1 milligram per 10 pounds. I never go over 0.8 milligrams once a day. And in the larger dogs, I'm going to dose at the lower end of the dosing interval, so 22 micrograms total per day, so 11 BID. So I start BID, and then I go, after I see that they're adequately supplemented and they're responding to medication, then I drop it to once daily after a month or two. I like to use a name brand medication, and my preference is to use Thyrotabs in dogs. In cats, I use the liquid form. Generic thyroid medications, if you want to use a generic thyroid, they must show bioavailability that's similar to Thyrotabs. And monitoring the therapy, generally the clinical signs of lethargy and mental dullness should improve within the first week. Same thing with other neurologic conditions like head tilts and facial nerve paralysis. Body weight reduction should be shown within 2 weeks, but it's going to take maybe up to 8 weeks for skin and coat changes because you have to wait for the hair to regrow in. And then generally the way I monitor these dogs is I start at my initial dose BID, And then I do either a 6-hour post-pill total T4 or an endogenous TSH. If I'm looking at the post-pill T4, I like to see it in the high normal, just over the normal range, 53 nanomoles per liter on average is what you like to see. And those that required a dose increase in this particular study, most of them were only getting into the 29 nanomole per liter range. And then the TSH is helpful since I mostly diagnose my hypothyroid dogs by TSH. All we want to see is that you suppress that TSH below 0.03 micrograms per liter. And non-responders still have TSH in the normal range. This is a graph showing a dog that had become hypothyroid by radioactive iodine. And you see that once they start him on the thyroid medication, that's that red arrow, and his TSH drops down to the undetectable range. Then he'd take him off of thyroid hormone, and about 10 days later or so, maybe even up to about 4 weeks later, we see the TSH comes back up, doesn't go quite as high as the initial sample at 2.5 nanograms per mil. Then they restart the thyroid medication, and you see that it drops back down. This is a 12-year-old male castrated German Shepherd dog. He was taken off thyroid medications 3 weeks ago due to epistaxis. He had really high blood pressure, so they took him off of his 0.8 milligrams once a day. When I brought him back in for testing, the owners presented him to me because they said he's starting to show signs of hypothyroidism again. His total T4 was undetectable. His free T4 was low normal, and his endogenous TSH was within the normal limits, but it was creeping up to that 0.4 nanograms per deciliter. So what I did is I put him back on a lower dose of T4 because he was symptomatic. So I put him on 0.4 milligrams once a day with a recheck in 2 weeks. So this is a little TRUFORMA platform. We have endogenous TSH on this platform, total T4, and soon we'll also have free T4. We probably already have that by now. So I love my little machine. It's very small and easy, compact to keep on the clinic floor, and I use it quite frequently. Also does cortisol and endogenous ACTH. So I'm going to stop there, and we can entertain questions or.
Yep, absolutely. Thank you so much, Dr. Greco. We'll give everyone a few moments to just post their questions in the Q&A box.